Yeah. So, how do you fit that in at the pharmacy? So, you've already got a lot going on. You've got a large retail front end, really neat boutique OTC area. You guys are doing compounding, immunizations. You're doing a lot. You mentioned you have a large team, but how do you really coordinate all of that? I know the appointment-based model has to accommodate that level of care, but how did you guys approach that?
Yeah, I think with just clinical services in general, having someone like me that is specifically focused on clinical services, I'm giving specific time during the week to just focus on those types of services, and then specific block time, to offer them to patients and offer the classes. So we have different pharmacists that have taken on different roles in different sectors to be able to focus on that one thing to do it well. So we have a pharmacy team leader that's focused on workflow management and making sure that's the most efficient that it can be and that everything is going well there. We have a compounding pharmacy manager, and that's Wayne himself, but he does everything with the lab, making sure everything with that is going well. So I think kind of dividing those roles and having different pharmacists take over different responsibilities. And then we meet once a week to come together to share what we're learning in our different aspects and how we can share ideas and make different things better. So I think that has been a good approach, is just having enough staff, enough pharmacists to give each of us the time to do what we need to do in our roles, but then having that time where we come together once a week to share different things that are happening to make each of those sectors better has been what's made it work so far, for sure.
Gotcha. So, kind of a two-part question. You mentioned that somebody had an improvement to your MedSync program earlier. So definitely want to know what that is and how that fit in. But then also, how do you identify these opportunities? So if you have a patient that maybe, gets a new, chronic disease state medication on their profile, is that something that you guys recognize at MedSync and then, trigger that kind of clinical follow-up, or what's the workflow for making sure that you're offering that care?
Yeah, so I think to answer your question, we just kind of have to go down the journey of the MedSync. That has been pretty much, like I said, a journey. We have tried out probably 3 or 4 different MedSync protocols, procedures throughout a year's time, and a lot of different things didn't work, where we weren't able to provide that level of care with looking at chronic disease state management, where we were behind, where we weren't growing our sync program, where our technicians were really stressed. So I think that could be helpful, I guess, to just go through what that looked like for us and where we are now, which is a completely different spot. We've actually reached 50% prescription volume with sync, which has been a goal for a long, long time. And I think the new program that we have has allowed us to do that. So I can kind of talk through, I guess, a little bit of what that looked like before and what it looks like now. If that would be helpful.
Yeah. Tell me what didn't work, and then tell me tell me how you fixed it.
Yeah. So, I think part of it comes to is that I am newer, so I'm just like, thank goodness I have a really forgiving team that has allowed me to just try a lot of different things. And so I would say the first thing that we had whenever I came into the clinical services role, we had one technician that was managing the entire sync program, which was fine because we had enough patients that she could manage herself, but we wanted to grow to get to 50%. So as we grew our patient base, we found out quickly that one person was not enough to manage all of these new people that we were adding to sync. So we ended up adding 2 more technicians, and we had 3 sync technicians that we split all of our sync patients into thirds, and they would manage those patients. Which was going okay, but again, because the health coaches were managing their own specific subset of patients, that added a little bit of stress to regular workflow, because if that person wasn't there during the day, or if they were off and that patient had a question, nobody else in the pharmacy knew anything about that person. That one technician knew everything about them, and nobody else knew anything. So that created a little bit of tension there with efficiency and being able to help the patient when needed. But then we ended up having some staffing changes, which ended up with us only having 2 sync technicians in our sync program, and they split their patients in half. And that is really when we, I would say, hit the rock bottom of sync, because we had a lot of patients and we had 2 sync technicians who knew their patients forwards and backwards, which had benefits. I mean, those sync technicians created very valuable relationships with their patients. They were the only technicians in the pharmacy, the only people that were talking to those specific subset of people. They were learning things about them that otherwise we may not have learned, because they were talking to the same people every month, creating those relationships. So with that aspect, we liked it. I mean, we liked that we were growing relationships with our patients, but there was a large amount of burnout among the 2 sync technicians, because, like I said, like they couldn't feel like they could take off. They couldn't feel like they could take a vacation, because when they did, they knew that if something happened with one of their patients, which at this point we're going to, they're having 400 patients that are their own. So that's a lot of people to have for one person to manage. And then if one of those 400 people have a question the day that they're not there, which is likely because that's a lot of people, we wouldn't know what to do. We'd have to contact them on their day off, and they just wouldn't feel like they would be able to take any time off. But and
there's only so many notes. There's only so much room, I guess, in the sync notes to really give that full picture. I mean, you can document, but I guess I can see where that's not very scalable to have that level of care.
Yeah, and the way that the workflow model worked, I mean, for sure the sync notes were helpful, but we had a workflow model where if someone called and it was that person's sync person, nobody else in the pharmacy was allowed to take that call. Like we went to that,
gotcha.
That's where the issue came, is because we wanted that specific person to have that relationship, but that's where there was some disconnect there. And then we saw our accuracy and our efficiency suffer because of that too, because it was a lot of patients they were trying to take on for 2 people that were only part-time in the sync role. Yeah, we were for sure having a lot of issues, as you can imagine. So that is what didn't work. As you can kind of hear from lacking efficiency, accuracy, all that kind of stuff. But luckily, one of our other, she was actually one of our workflow technicians, but she is just someone that has really awesome ideas. She came in and said, hey, what if you didn't have each health coach have separate patients? What if you incorporated 2 more part-time health coaches, which we're now, I'm now using different terminology. We're calling them health coaches, kind of separating them even more, giving them kind of a different clinical title. We have, she said, why don't we do those 2 people? They're the 2 main health coaches, but then we have 2 backup health coaches that can answer questions if they're not there. And instead of having our patients split, all of the patients are going to be together, and each day they're going to split the patients in half. So maybe the one of our girls isn't talking to the same person every single month, but there's still only a group of 4 people that are talking to that patient. So there still is relationship building there, but we're able to improve our efficiency, accuracy, all of that. And ever since we switched to that system, it has been just a complete game changer. We've been able to add patients without compromising accuracy and efficiency. And that I feel like that model so far has been working out the best that we've had.
Yeah, it definitely seems like that would make that a little bit more flexible. So I guess everybody in that case also kind of has the same playbook on, all right, here's what to do when we see this, right? If there's, a new medication added, is there a specific protocol to make sure that those patients are invited to the boot camp, or, somebody's going to take that patient aside and go over the opioid pledge, right? Like how do you handle those situations to make sure that it's consistently followed through?
Yeah, so notes are a big thing for us, having notes in the critical comments, having notes in the sync comments. So, for example, we're part of CPSN's UPMC asthma program. So anytime we have one of those eligible patients that's also a sync patient, I will put in the sync notes for that person to do the asthma questionnaire with them. So we're not repeating service, but we're providing our MedSync call and then offering the UPMC asthma service so that I can send off the e-care plan for that. Or if there's someone that needs an opioid pledge, that is something that's more down to our will call end. So maybe we're putting a point of sale comment in saying when this person picks up their medication, make sure you review the opioid pledge with them. So it's making notes at, for whoever is going to be the best person to accomplish that job that I think that's helped us. Helped us with that for sure.
So tell me a little bit about the opioid pledge. If somebody is listening and they're like, opioid pledge, it sounds like just a kind of a standardized thing, the way you named it. But maybe that's something that not every pharmacy is currently doing. So talk a little bit about that.
Yeah, so the opioid pledge was part of a Flip the Pharmacy change package. So we can talk a little bit more about that too. But with the change package with Flip the Pharmacy, they would give us a breakdown of what that month's focus was going to be on and different tasks that we could do to make the pharmacy more clinically focused. So one of those was to create an opioid pledge. And that basically means that it has some different bullet points that show what the pharmacy is responsible for and then also what the patient is responsible for. So it's laying out for the patient that if they're picking up an opioid medication, and this is for chronic opioid management. So if someone's getting a 30-day supply and they've gotten, I would say, 1 or 2 fills of a 30-day supply, that's when we're giving them the pledge. And that's outlining that the pharmacy is responsible for checking the PDMP. The pharmacy is responsible for making sure that the dosing is appropriate, that everything on the prescription is legally correct. And then it's saying exactly what we are expecting of our patients. So we're saying patients are responsible for keeping their medications from getting lost or stolen. They're responsible for not asking for their fill more than 3 days early. That's our cutoff. They're responsible for getting all of their controlled medications at one pharmacy. So we have, I would say, maybe 10 different bullet points that we have them read, and then they sign the pledge. And then they also sign whether or not they have a Narcan. And if they do not, we will always recommend to fill a Narcan on the spot for them. We'll take that e-care plan. We will scan it into the patient's documents or take the opioid pledge, scan it into the patient's documents. And then I'll send an e-care plan off to CPESN documenting that we did the opioid education and that we offered Narcan. So it sounds like a lot, but it really doesn't take that much time. We've kind of gotten to a groove of doing it, and everyone has just been able to kind of incorporate that into workflow now. But it's something that we do that I think protects both us and the patients.
In 2017, a law in Washington State went into effect that allows community pharmacists to basically participate in medical billing for any clinical services. So it's that provider status that we'd all been seeking. We finally had that mechanism to do it, and so we jumped on it and went through the credentialing and contracting process. And we're able to contract with a number of the large commercial health plans in the area. And we'd already started our prep clinic, and it was kind of a different model from what it is today. And we adapted it around this opportunity with provider status billing. And so our prep clinic is unique. It's a pharmacist-driven clinic, and it actually started as a residency project. We have a community residency program, and our resident and one of our clinical pharmacists came up with this concept of providing prep, and this was at a time when nobody was doing prep. And
Nice.
they pitched it to us as a concept for a project, and sounded amazing. So we ran with it, and so it's all pharmacist driven. Everything happens in the pharmacy. So somebody interested in HIV prevention, they schedule an appointment, and they come in and meet with the pharmacist. We do all of their labs in the pharmacy, and if appropriate, they're initiated on PrEP, and all of this happens in one visit in about an hour. So we call it one-step PrEP. It's one of those things that we've just been able to find ways to remove all of the barriers to patient access and make it really easy for people. And it's been absolutely phenomenal. And it's grown to the point now that we're actually able to bill for our time and not worry about the reimbursement on the product, that it is fully self-sustaining, and we're actually building and expanding out just clinical services at this point, because we've got a model that works. So it is possible.
That is so cool, man, because that's like really the ideal scenario. I know so many pharmacies across the country would just, are saying, see, this could work. We can take so much burden off of the healthcare system. We can move that burden over here. Pharmacists are trained to do that. We have those connections in the community. Put me in, coach. But up there in Seattle, you guys have been able to really take that model. So if anybody outside of the world of pharmacy is watching this podcast, they may not realize that pharmacists, even though they're trained in a lot of states, a lot of areas, can't use their training to provide those services that they could provide so well. And even when you have pharmacies that do, a lot of times they're offering those services and not being reimbursed for them. So, it's really like the pinnacle of that, operating at the top of your license, where you're performing those labs, you're taking those clinical results and documenting, e-care planning, providing the prescriptions that accompany that use case. And then, really it's like you said, that one-stop shop. So I guess two-part question, where do you see that moving forward in your community? I know there's some other areas that you can apply that, but then, what do you think the holdup is in other states that haven't granted that provider status?
Yeah, well, as far as other states go, I know there have been a lot of great efforts around the country, and other states are starting to see some progress there. And I know there's a handful of other states now that have similar laws on the books. So I think we've got some good model legislation out there now. So it's just a function of staying engaged with your legislative efforts, and partnering with organizations that are going to support that messaging. We had great partners in the schools of pharmacy here in Washington State, and the Washington State Pharmacy Association really led that charge. But supporting those efforts, supporting your professional organizations so they can get that work done. But it's coming. It's not coming as fast as it should, but we're getting there. And I think we've got some really good examples of how we can provide collaborative services to our community that improve outcomes, reduce costs. And as far as where we're going with this, it's always a great question. But there's we're still putting energy into PrEP, but I think there's just again working with public health. I think there's so many opportunities where we can do things that are collaborative, that are going to engender the support of the healthcare community. So hepatitis C is kind of our next big effort. And I'm still very much interested in overdose prevention efforts. So with some of the populations that we work with, all of these things are sort of coalescing. And so we're trying to figure out, okay, how can we take what we do and take it out further into the community? So we're working with, again, I mentioned, some of the local organizations here that are providing supportive housing as they transition people from homelessness into supportive housing that have some form of integrated health care, taking our pharmacists and embedding their services within these organizations to kind of expand our reach and expand the offerings that we're providing in the pharmacy, taking it to the point of need. So that's kind of my vision for where some of this is headed. But it's I think there's plenty of opportunities out there, but you have to be willing to look in non-traditional places to find them, I think.
Yeah, absolutely. I think you're right on there where, when you look at a lot of these problems, they do kind of compound on each other sometimes, and being there in the community, treating those, those root causes, those social determinants that are going to lead to other challenges is really the key. And I think, like you said too, once you have other states who are looking at legislation, having those successful use cases, saying Kelley-Ross can do it, here's the difference it made in their community, So are you able to work with any of your, local governing bodies and show them the fruits of your efforts and kind of say, here's where the rubber meets the road, and here are some statistics on how we've made that positive change?
Yeah, it's all about the data at the end of the day, isn't it? We've done that. We've done that both with our some of our naloxone efforts, and that's where some of those partnerships really come into play, because public health really has an interest in these issues, and they they often have the resources to do that. We work very closely with the University of Washington School of Pharmacy. We're all my partners and I are all alums. We have a lot of UW pharmacists here, and we're preceptors. So we do a lot of training. So having that close organization with the School of Pharmacy, I think has helped with some of those efforts. But you're right. You've got to be able to prove that what you're doing really does make an impact. And finding ways to track that and present it is key.
Another thing that you've done outside of the PrEP program is really just focusing on medication coaching. So again, taking that, beyond medication, but really understanding and lifestyle changes. So how have you kind of seen that work out in your community?
Yeah, well, I mean, I think that's something that all pharmacists are endeavoring to do in one form or another. And again, we try and find novel ways to do that. And one program that I think is really remarkable has come through a relationship with our area agency on aging, Seattle Aging and Disabilities. And this has been a relationship we've been developing, I think, since I was in pharmacy school. And it started with a case manager calling up and asking me if we could do Medisets. And I'm like, yeah, we do Medisets. And like, oh, could you do them in this situation? I'm like, yeah, we could do that. And we'll deliver it. And, it started as simple enough, but it's grown and evolved into something completely different, where it has nothing to. We actually don't dispense any medications for clients that we're partnered with through Aging and Disabilities, but we've contracted with King County to provide what's called the Senior Drug Education Program, and so Pre-COVID, a pharmacist would actually go out to should be assigned buildings that were operated by this group. And it might be SHAG as one of them, but there's, every community has something like this.
Sure.
But we're able to contract to cover the pharmacist's time to go out and provide group coaching around medication-related issues, fall prevention, you name it, all of those topics that pharmacists are experts at, and provide classes as well as one-on-one coaching, medication reviews, and doing all these off-site at these different buildings has been very well received, and we know it's making an impact, and we've been able to figure out a way to sustain that over time. That was another one that we had to pivot during the pandemic and figure out how to do all of this stuff remotely. And again, that's where that, helping educate seniors on how to use some of this technology was challenging, but
Sure.
Finding ways to make that happen. So yeah, that's I think that's one example of how we've been able to take that traditional medication coaching concept, take it into the patient's home, where they're most comfortable to receive that information. And you learn a lot more as a provider when you can meet somebody on their terms, and I think you can have a bigger impact when you can see how they live. They're more comfortable talking to you about their medication challenges, and at the end of the day, you can have a better interaction.
Oh yeah, just having somebody there where that person is at every day, you may pick up on so many pieces of information, so many pieces of the puzzle that you just couldn't have seen otherwise. I love there's one of the early podcasts we had Joe Williams who talked about the difficulty in just getting in and out of their driveway because there was a limb that needed to be cut down. So, this is a small community adaptation, but he showed up with a chainsaw, and took that limb down for him. But, those are the kind of things that you really can't see. Is there like a, medication storage issue? Is there a slip or a step or, all of those things are just hard to really understand if you're not there where they're at.
Yep, exactly.
This, I think, has been, such a great opportunity for pharmacists to really flex their clinical muscles and show how we can make an impact on the greater community population health.
Yeah, it's been, it seems like this comes up in every conversation, not just every podcast, but like it's hard not to talk about because it is such a big elephant in the room. But it's been neat to see that silver lining of how pharmacists could step up and really be noticed for their role and how they can affect healthcare and those big differences they can make in their community. And to see so many of those pharmacists out there like figuring it out, because it's kind of been the Wild West with this COVID immunization process from, day one, really. But it's been neat to see the pharmacists who are out on that front line to secure, that super cold storage and, get signed up with the correct agencies to be able to get the immunization and then it's been wild.
Yeah. And even, I remember last year at the beginning of the pandemic, my husband and I were in Cairo, Egypt, when the pandemic broke out. And I was speaking at the Arab International Pharmacy Conference in Cairo. We flew down to Luxor. We did the Valley of the Kings, was enjoying Egypt. But at that time, this was like March 6th, around then in 2020. And the only channel on TV that was in English was the BBC. So we had been watching the BBC and Italy was shutting down.
Oh, gosh, yeah.
The only places that were open was pharmacies and grocery stores was pretty much it. And we were starting to get nervous. Like, are we going to get stuck in Egypt with, I was pregnant again with our third child. and our other two kids were at home with my mom and my husband's mom. And we were really thinking, what's going to happen? But I remember at the beginning of the pandemic just being so proud that, that pharmacies were really being recognized as such an essential part of daily life, that even during the beginning of the pandemic, when everything was shut down, pharmacists were still there to hold the front lines. And, that's something that I'm going to continue to tell that story for the rest of my life until pharmacists get the recognition and get the provider status that they deserve.
Yeah. So going back towards the MTM area, it really seems like that was like a shift in thinking of somebody outside the pharmacy walls recognizing, hey, here's where all the savings are. This is where the prevention lies. This is where the boots meet the ground, and we need to incentivize this. We need to, use this tool better. And so, when you first see these other entities, like that's got to be really encouraging for the profession to be like, yes, we told you, like we've been trained on this. This is what we're passionate about. This is what we've been doing for years and not getting paid for. So it's been neat to see that grow into like the documentation that we have now, where we have new standards coming out for, e-care plans, where it's really quantifying that scope of work. So like, how do you see that ability to quantify your efforts and document like what you've done and how it's had those positive effects? Like, where do you see that kind of pushing pharmacists to in the next, 5 years or 2 years?
Yeah, so there's 3 predictions that I have for the next 10 years or so. One is that really pharmacists are going to come out on the forefront of preventative services. I see functional medicine, integrative medicine, this shift from, being 100% reliant on modern medicine for our preventative services to this holistic, that's been on the fringe, the acupuncture and the nutrition and some of the stuff that we've seen in Eastern medicine for a long time. So I'm actually working on my master's in Ayurvedic medicine right now, because I see there's so much opportunity that we can remove some of the obstacles and help our bodies heal themselves. Mm-hmm. So that's my first prediction, is really around pharmacists becoming the go-to source for preventative health. The second would be less reliance on dispensing for revenue. So with the, shifting to the clinical services, the e-care plans, these opportunities for billing in other ways, I think that our business model will become more diversified, which I see as a good thing. And then the third big shift that I see happening in the next 10 years is pharmacists being embedded in ambulatory care clinics. So working with doctors, just like, my mom's a nurse practitioner. So I remember this was probably almost 20 years ago now, and she was going through her master's program, and she cannot type on a computer at all. So I was in high school typing up her master's program notes and all of her essays, because she would just write them on her, notebook paper, and then she would like make me type them up for her because I could type so much faster than her. And so, 20 years ago, no one had heard of a nurse practitioner in a physician's office. No one had heard of a physician's assistant. The next 10 years, my hope is that, and I do think that it will happen, because I talk to physicians and clinics all the time who are asking me, where do I find these clinical pharmacists that can help us with our quality metrics? We had kind of touched on adherence and star ratings. When you start digging into the quality metrics that the physician's office has to meet, CMS passed new legislation in 2017 called MACRA. And that act was basically creating quality benchmarks for ambulatory care clinics. So there's 2 tracks that they could do in this quality payment program. And it's pretty much all based on patient outcomes and performance. So if their patients are outside of their A1C goal, these physicians are going to get dinged, come 2 years down the line when CMS starts looking at their data and they're saying, I mean, you've been seeing this patient for, 4 years and their A1C is still outside of where we want it to be.
Right.
What gives? And I think having the pharmacist there to step in and ask some different questions of the patient and, be able to spend more time with them talking about, is it lack of adherence, or is it, is it diet? Is it exercise? Is it other medications interacting and playing a role with this? There's so many opportunities, I think, because pharmacists we're trained in a completely different way. I like to say that physicians are really trained to diagnose, and pharmacists are trained to manage these chronic conditions. And so some of my clients now are working with collaborative physicians in these collaborative business agreements, collaborative practice agreements, to be able to offer chronic care and remote physiologic monitoring services remotely for their local collaborative physicians. And it's been a win-win, because pharmacists, even though we don't have provider status, we have these opportunities to make an impact on patient outcome, which translates to hundreds of thousands of dollars for the clinic down the line when you look at quality benchmarks. So
it's like the Zig Ziglar quote where you can have everything you want in life if you help other people get what they want.
Exactly.
And I don't think he was talking about healthcare or medicine, but, I think for the pharmacy, their value really lies in that win-win scenario. But I feel like the pharmacists have been somewhat like in a silo. They're doing these amazing things and not communicating that or passing that with the other members of the equation. So, how do you increase that communication? How do you get that buy-in from a physician where it's like, hey, you're trying to reach these goals, you're getting pinged on this. That's exactly what I can help with. How do you start that collaboration?
Yeah, so this was really, what we were going to focus on for this, converting these free consultations into clients. Whether your potential client is a patient who may be interested in your functional medicine program, or a physician, a local physician that you want to go talk to about a collaborative, remote patient monitoring program. But getting comfortable with selling, and just by knowing a few of the frameworks that we talk about for selling can really help you to not necessarily persuade, but just to help other people get what they want. And you can also, be able to grow your revenue and grow your clinical services and really generate demand for pharmacist-led services in this way, just by knowing how to talk to people about their needs. So there's 4 A's that we teach in the Pharmapreneur Academy, which is, you start with asking. You just ask, what are you struggling with? What kind of results are you looking to get? If you're talking with a patient, what are your health goals? If you're talking with a physician, what quality metrics are you reporting on this year? Just trying to figure out their pain points. And then, assessing, is there a way I can maybe help this person before agreeing upon what the service could actually look like, what that program would actually look like, and then finally accepting and making an offer for that arrangement. So I think most of the time we think selling, because it's such a subtle art, we think selling is going in and handing someone a flyer and waiting for them to call us back, or like doing your pitch and expecting to get, your phone blowing up. And it's really more about relationship building and creating a customized program for the clients you're working with so that they can feel like their needs are priority number one.
So do you have like any tips for like preparing that conversation? So, if I have a fantastic pharmacy software in my pharmacy that allows me to run, great reports, is that something that you would do ahead of time, is maybe look at that prescriber in your system, see what kind of medication, see what kind of, are there trends with therapeutic classes or disease states that you could really kind of bring those tailored solutions on step one, or do you kind of put that later in line?
Yeah, so that might be like a great just icebreaker kind of question for that physician, to call them and say, hey, I've got this fantastic pharmacy software. I can run a report on pretty much anything that you could possibly want. What are some challenges that you guys are dealing with? It may not be with managing diabetic patients. Maybe it's with COPD patients, and you can really isolate and run reports for people who would be a good fit. So, you can imagine if you could run a report that shows a physician what patients they have, what medications they're on, that they're outside of goal, but then you could offer that physician a collaborative opportunity to where your pharmacy is helping them manage this patient's care, get their COPD or diabetes or whatever it is under control, and they can get paid additionally for this service. That's what chronic care management is. And it's a 20-minute non-face-to-face clinical service once a month. You get reimbursed. I think average national reimbursement is around $42. It has to be billed through the physician's MPI, and it has to be consented by the patient. So they have to sign consent that they're interested in this service. But when you think about it, if you have a MedSync program, you probably already are calling these people and spending 20 minutes a month working on their medicines. So to me, that it's just a win-win situation that, hey, pharmacists are already doing this. And then you get a collaborative provider on board, and you can get this patient the outcomes that they're interested in, by asking what their quality metrics are. You create a plan, a customized calendar that your pharmacy, even technicians can be involved in this, calling the patient, just getting set up for prior authorizations and refills. All of that counts as dedicated clinical staff time.
If you enjoyed today's episode, please like, subscribe, and follow us wherever you get your podcast. Give us a 5-star rating on Apple Podcasts to help us reach more pharmacy professionals like you.